Good afternoon to all dignitaries and delegates. The world is full of diamonds and gems, and we are fortunate to have some of them here today. For the first session, it gives me immense pleasure to extend a very warm welcome to our respected chairpersons, Dr. B.K. Roy, Senior Consultant Endocrinologist, Apollo Hospitals, Noida, Dr. Harish Vashisht, Senior Consultant Psychiatrist. Over to the chairpersons.
Hello. Thank you very much. And dear friends, I welcome you all to this interesting post-lunch session of SPEEDCON. And the next talk is on quest to put peptide in a pill, developmental clinical journey of oral semaglutide. As you all know, there are many peptide medicines like insulin, like GLP receptor agonists, which are very effective, especially like GLP receptor agonist. Semaglutide has been shown to have very good glycemic control, good weight loss, and cardiovascular reduction properties, along with probably improved beta cell function. But because of this being injectable, use of this has been less acceptable among patients. Patients, as you all know, they always want oral tablets. So, luckily, this no Nordics have developed oral formulation of a semaglutide by name of Ribelsus, which is FDA approved in 2019, and it has shown quite good efficacy in lowering HbA1c, good weight loss tendency, capabilities, and it had not a very significant side effect profile also. So, our speaker for this topic is Dr. S K Wangoo, who is Senior Consultant Endocrinologist and Diabetologist at Apollo Center for Obesity, Diabetes and Endocrinology in Apollo Hospital, Delhi. You all know him very well. He has been a regular speaker in our medical forums, and he's established and currently heading the Apollo Center for Obesity, Diabetes and Endocrinology. Has numerous publications in international, national journals of repute, is on various advisory boards and guideline forming bodies. He is actively involved in teaching and training of DNB endocrinology students for just last 8 years, and the only among the Apollo group of hospitals having DNB endocrinology group. And I know him very well. He is a very dedicated clinical endocrinologist and good speaker also. I invite Dr. S K Wangoo to deliver his talk. Dr. Wangoo, please.
Thank you, Dr. B.K. Roy, and welcome to the post-lunch session. I think most of you must be having postprandial sort of a siesta. You know, you feel very lazy, you want to sleep after taking a sumptuous lunch. But nonetheless, I will try my best to keep you awake. So, these are my financial disclosures that I have been commercially supported by the Novo Nordisk for this promotional meeting in return for providing a service. Today's my agenda will be what is the role of GLP-1 receptor agonist in the management of type 2 diabetes, pioneering a new era, triumphing targets with the oral semaglutide, and pioneering management in the routine clinical practice. Now, we all are looking forward for an ideal oral anti-diabetic drug. And what should be an ideal oral anti-diabetic drug? It should be basically able to have a low risk of hypoglycemia. It should be having a good efficacy to control blood sugar with a significant reduction in the HbA1c. There should be no weight gain with the ideal oral antidiabetic drug, and of course it should be associated with the weight loss, and also it should have some off target or minimal off target effects. If you see the mechanism of the GLP-1 receptor agonist, all of you know very well the differentiose ominous octet, the 8 underlying fundamental physiological defects in pathogenesis of type 2 diabetes. And if you see the GLP-1 receptor agonist targets 6 out of the 8 core defects evident in type 2 diabetes, and thus we can say that this is the one drug which is ideal. Like these are the 6 out of 8 on the incretin effect, on causing the increase in the insulin secretion, increasing the suppression of the glucagon secretion, and also improving insulin resistance, and also suppressing the increased hepatic glucose production from the liver. So these are the multi-mode action of the GLP-1 receptor agonist. Now the problem of the challenge is that once we started using the GLP-1 receptor agonist, as Dr. B.K. Roy told you, the problem was that most of the time the patients were reluctant to start the injectable therapy for the treatment of type 2 diabetes. Initially, when the GLP-1 receptor came into the market, it was to be given on the daily basis, twice daily injection, and the first GLP-1 receptor agonist which came to the market was Byetta, the Exendin 4, which was basically manufactured by the Eli Lilly company. Then came the single OD dose of the liraglutide, the Victoza, and which ruled the market for many, many years with some of the fundamental good results, and even after the leader trial showing the good cardiovascular benefit of the liraglutide, the popularity of the GLP-1 receptor agonist rose much more in the clinical practice. Then came the weekly GLP-1 receptor agonist, the weekly dulaglutide. Unfortunately, the weekly injectable semaglutide could not find its place into the Indian market, but the weekly dulaglutide was launched, and it showed some good response in terms of weight loss, the glycemic efficacy, and you had on board some of the good cardiovascular safety data in terms of the rewind trial. All said and done, but the quest for making this peptide in a pill in order to avoid the injectable preparation was a sort of a breakthrough research and excitement for all the endocrine professionals all over the world, when Novo Nordisk brought the good news of successfully bringing the peptide in a pill and avoiding the injectable preparations for the treatment of type 2 diabetes. Because the fear of injection may still remain a barrier to the use of a GLP-1 receptor agonist in both patients and physicians. There was a global internet survey of more than 1,200 physicians reported that having too many injections is associated with the poor adherence to the treatment in patients, and 26% agreed to that. Now, what do the patients prefer? The patient prefer we have a very long journey in order to improve the patient's preference and the convenience and the adherence of the injectable therapy. We started with the injectable therapy with the vials and the syringes. Then we have pens, the smart pens, to deliver the insulin subcutaneously, what you call the tailored engineered pen injectors. And of course, we are here to present to you the first oral peptide in a pill for the convenience, for the adherence, for the similar efficacy as compared to the GLP-1 receptor, injectable GLP-1 receptor agonist. Now coming to the second, the pioneering a new era, the delivery of the oral peptide. The rationale behind the research of giving this oral delivery peptide was basically based on the unmet need of the majority of the patient, and to give them a molecule which was safe, non-invasive, and convenient mode of therapy. It also led to the improved patient compliance and expanded the treatment options. Early commencement of the treatment regimens for the better patient glycemic control, and it has also addressed the many of the barriers or the inertia both from the physicians and the patients about the injection phobia or the administration of the subcutaneous insulin therapy. So the journey started with the quest for the first ever oral GLP-1 receptor agonist, the oral based drug. The problem with the oral based drug, what we have been facing till now, even as regard to the other molecules like insulin, which we have not been able to really have insulin basically given in form of the nanoparticles in the capsules, but the peptides, the larger peptide, had the problem of the enzymatic degradation because the low pH of the stomach and the proteolytic enzymes in the stomach cause rapid degradation of these large peptide molecules. And also the limited permeability across the GI tract or the GI tract epithelium was a major hurdle in making this injectable preparation into an oral tablet. And third thing, the GLP-1 receptor agonist administered alone have a very low oral bioavailability unless and until you give some absorption enhancers with it so that you have a complete absorption from the stomach. And in order to avoid all the three important parameters, the enzymatic degradation, limited permeability, low oral bioavailability, we had to put the pill, the peptide in a pill that basically escapes the degradation from the stomach and can be absorbed easily. Now coming to the structure, how this recent innovation or this what you call the breakthrough innovation was possible to make this peptide in a pill. You know, the semaglutide, if you know, structurally has a 94% homology to human GLP-1, and the T-half is approximately 1 week. And if you see that one of the amino acid at position 8 is substituted, that is alanine, to the alpha amino isobutyric acid, which protects against the DPP-4 degradation of this peptide. The second was a spacer, and the C18 fatty acid diacid chain was attached with the lysine at 26th position of the amino acid sequence to provide a very strong binding to the albumin. You know, Novo has been most of the time researching with all their molecules which are basically with the albumin binding and causing a fatty acid side chain to basically help the molecule to have a more binding to the albin. And third, the final step was to amino acid substitution at position 34. Here the lysine was substituted to the arginine, which prevents the C18 fatty acid diacid binding with the side chain to act on a wrong side. It has to be acted on the 26th position of the amino acid sequences. In order it should not go and attach on other amino acids, this substitution of lysine to arginine was done at a position 34 of this semaglutide molecule. So this discovery of making the structural alteration led to the path-breaking innovation in bringing GLP-1 receptor agonist in a pill. The problem of the absorption, what I told you. So we could solve the problem of the enzymatic degradation by putting it inside a pill, the molecule, so that it can prevent the degradation. And in order to enhance the absorption, we had to add an absorption enhancer. And why semaglutide was used to be research molecule? Why not the other GLP-1 receptor agonist to be put in a pill? Because it's the most effective GLP-1 receptor agonist tested to date. That is why the scientists chose this molecule semaglutide to work it in a pill. And also the associated long half-life of 1 week was important in the development of this molecule. SNAC is the basic, what you call the player in delivering the oral semaglutide, and this is an absorption enhancer which promotes the semaglutide absorption across the gastric epithelium. If you want to know the full form of the SNAC, it is written here on the down. Just think that it is nothing but a absorption enhancer which will cause the enhanced absorption of the semaglutide when you combine the SNAC with the tablet. So now here are two things with you. One is the semaglutide with the structural changes, and then you have an absorption enhancer. Then you combine both in a pill, what you call a peptide in a pill. This is the first of its class of oral GLP-1 in a pill, and I think this will be the one of the most important scientific breakthrough innovation. A new oral administration of the GLP-1, only possible with an absorption enhancer. Bioavailability is low, but the variability in absorption is higher. Mitigated by the 1 week half-life and once daily dosing, several treatment doses has been basically approved for the better outcome of the oral semaglutide, and the patient compliance with the dosing condition has to be kept in mind before you prescribe. Now coming to the various, I will just take 2 minutes more with the permission. Lot of clinical trials and work are behind the development of this molecule. There has been more than 24 clinical pharmacological trial, 1 phase 2 clinical trial and 10 phase 3A clinical trial. Until now, the subjects exposed to the oral semaglutide has been more than 5,700. And they have been nicknamed as pioneer trial 1, 2, 3, 4, 5, 6, 7, 8, 9 and 10. If you focus the pioneer 6 trial, which was the only trial in the Indian subject to look at the cardiovascular outcome trial, while the other pioneer 1, 2, 3, 4 and 7 were up for in comparison with the placebo, SGLT2, DPP4, GLP-1 and with the insulin. But the pioneer 6 was important because FDA mandate to show the CV safety efficacy of these oral molecules. And if we see the on an average reduction of the HbA1c at the end of the treatment, the maximum HbA1c reduction, if you see in the pioneer monotherapy, was up to the tune of 1.5%. In the change in the across the global pioneer trial, the semaglutide achieved A1C reduction up to 1.5% in the monotherapy trial. Similarly, percentage of patients who achieved less than 7% at the end of the treatment were significantly higher in patients who were having high baseline HbA1c. So, all the trials, 7 out of the 10 patients achieved HbA1c of less than 7% with oral semaglutide. Similarly, change in the HbA1c with a much higher level of more than 9%, you can attain maximum up to 2.6 decrease in the HbA1c when you are using in a patient with a very high HbA1c. And the time spent in glycemic control was maximum when you use the oral semaglutide as compared to the other SGLT2 inhibitors. Change in body weight on an average 3.5 to 4 kg body weight loss with these molecules across all the pioneer trial. And patients who achieved more than 5% weight loss were again more with the semaglutide. Last but not the least, I will tell you about how to take this molecule in your day-to-day clinical practice. After having said about all the pioneer trial, looking at the HbA1c, weight control, proportion of patient achieving less than 7%, proportion of patient having higher HbA1c, how you can best deliver this molecule in the day-to-day clinical scenes. CV outcome trial has been already addressed. You know, the tablet comes in 3 strengths, 3 milligrams, 7 milligram, and 14 milligram. First thing you have to tell your patient that take this molecule early in the morning, empty stomach, with 120 ml of water, not more than that because of the better absorption, and can start eating after half an hour, whatever the medicine patient has to take it. First month you continue with the 3 milligrams, second month you increase the dose to 7 milligram, and the third month onwards you have to continue with the 14 milligram. We are doing trials on the higher dose of semaglutide in our hospital, having say around 25 to 50 milligram, whether we can achieve more reduction in the HbA1c or the more reduction in the weight with the higher dose of the oral semaglutide, which might come when we finish our trials. So this was basically, in short. I think because of the paucity of time, I will be happy to take more questions related to your clinical doubts when you want to prescribe this drug in your clinical practice. So this is my summary, basically, impact on the HbA1c, weight, CO safety, and overall safety. So clinical practice, I have told you the drug dosing, the drug schedule, what precaution you have to take it. So thank you very much for your kind listening, and I'll be happy to clear the doubts among the treating physicians who want to start this molecule in their day-to-day clinical practice. And yes.
This is tablet is to be given empty stomach. Any role when you are giving altroxin in the morning, empty stomach? Is there an interaction between the
No.
two tablets? No trial is available. You can give
No
together.
trial is available. You can give, even the PPI can be given. I have seen no trial
But
saying
with-
that.
No, with PPI and altroxin, there's a
PPI, so you have to give 3 hours gap with the
reduction in
altroxin.
the altroxin.
What I tell my patient, though you can give it along with, I tell the patient the best thing, you get up early in the morning, take the altroxin, go off to sleep, and when you get up in the morning around 7, you just get up early in the morning, 5, 6, take the altroxin, go off to sleep, and when you get up for the breakfast, or in the morning 8 o'clock, take this pill and have your breakfast. But otherwise you can take it.
Yes, just please wait. Due to lack of time, we'll take question after this second talk. If
Oh,
possible.
sure.
Because already. So thank you, Dr. Wangoo, for such a nice presentation. It was a very nice, clear presentation, and